All right. Hello, everybody. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Tercera Therapeutics. My name is Rain Bennett. I am your host, and I am a filmmaker. I've been working with CCF for almost 10 years now, which has been an incredibly rewarding journey for me. I'm really grateful to be a part of this community. I've learned so much, and I really enjoy helping share the stories of the members of this tight-knit, powerful community. And typically the projects that I do with CCF are different forms of video projects. Sometimes they're produced videos, sometimes they're live video series like Luncheon with the Experts. But overall, our goal is still the same, is to spread awareness and education about neuroendocrine tumors. So if you're just signing on with us today and you're a regular, you know the drill. Let us know where you're signing on from. Tell us hello. Okay, we see some people signing on already. Great, got some good numbers. So before we get started, I want to thank Tercera Therapeutics for their support of the series. Without them, this wouldn't be possible. And we have a quick disclaimer from the sponsors that just say the opinions expressed by the guest presenters, as well as the questions asked by the audience, that's you all at home, haven't been created or suggested by the sponsors of the Facebook Live program, and CCF does not endorse or promote any of the views, opinions, or information provided in this presentation. So audience members, that's you all at home, should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. So all that is saying is that we won't be able to get too case specific for your cases today. We're going to hope to provide you some general direction, advice, knowledge, information, but by all means, discuss any decisions you want to make with your home team as they know your case. So today's guest is Dr. Simron Singh. How are you, Dr. Singh?
I'm great. Thank you. Thanks for having me.
Yeah, thanks for being here. So tell us a little bit about yourself and where exactly you fit into this world of neuroendocrine cancer. What exactly do you do and where do you do it?
Sure. Thanks, Ray. I'm a medical oncologist, which means I treat cancers with medication, or whether that be oral pills or chemotherapy or injections. But I'm not a surgeon or nuclear medicine doctor. I'm a medical oncologist. I practice at Sunnybrook Health Sciences Center. We have a cancer center here called the Odette Cancer Center, and that's affiliated at the University of Toronto. So I'm in Toronto, Canada.
So what percentage would you say out of the cancers that you treat are neuroendocrine cancers and neuroendocrine tumors?
So I'm a bit unique in that I only treat neuroendocrine cancers.
Okay.
This is my whole practice. We have a clinic here that we've developed named after one of our donors called the Susan Leslie Clinic for Neuroendocrine Cancers. Mm-hmm. And so we have a specialized clinic. So my job is 100% neuroendocrine cancers all the time.
Interesting. Okay, that's gonna definitely provide some questions. I've got some questions that I want to ask you. We'll put a pin in that for the moment. So everybody at home, you know a little bit about our guest today, Dr. Singh. With Luncheon with the Experts, we really try to dive into the stories behind the guest, what led them to this role, how they serve the community. You all at home, if you're a regular, you know how I feel about this community, and it's always interesting to me to see the different members of it and how we all fit together, because honestly, I think especially with a rare disease like this, it takes every bit of us kind of fighting to get the understanding of this rare disease out there. Now, just know that we might not be able to get to all your questions. As I've already said, we can't get to super case specific questions. So try to answer or ask rather in general terms that can give you the guidance that you seek to help get you to the next step. Sometimes I've noticed over the past couple of weeks, people think that the more information they give about their case, the easier it might be to answer. And it's not actually. In fact, it's a little harder to read. So think about how you can simplify your questions that still give you the guidance that you need without giving us every single detail about your case, because we unfortunately just don't have the time to get to everybody. But that being said, once the program is over, if you have follow-up questions, I strongly urge you to reach out to the Carcinoid Cancer Foundation, either here on their Facebook page where you are, you can direct message them, or on their website at carcinoid.org. And I promise you they will work to get you that information or that specialist or the direction and guidance that you need. One more thing about the questions that are asked. I see the comment thread on the side there, and there's a lot of questions that come pouring in, and you guys have a lot of side conversations going on, which I love. That shows, you know, the element and aspect of community right there. But if you see a question that you like or you also have, just like that question or love it. Hit the like button beside it, because that effectively upvotes it. It lets me see that, oh, there's a demand. There's 5 or 6 people that also have this question or would like the answer to this question, and then I can make sure that that gets through, because unfortunately we can never get to all the questions. Lastly, before we get started, we wanted to say, have you downloaded, or ask rather, we wanted to ask, have you downloaded CCS free Net Cancer Health Storylines app? The app makes it very easy to record your symptoms, medications, nutritional concerns, moods, and more. So check that out. It's another way that we can help you along this journey. So everybody's sending your questions. I'm going to get back to Dr. Singh because I have some questions. 100% of your patients are neuroendocrine tumor patients. How and when did all that start? I'm assuming that when you came out of school, you didn't directly jump into that field. So I'm always very interested in you know, what was the moment where you decided this was the disease that you really felt moved to try to help?
It's a great question. And I think it kind of goes back to what you were saying, Rain, about this being a community where everybody sort of needs to stick together. It's it's a close-knit community, but it's a very cooperative and supportive community. And part of that has led to this, where I am today. So I was actually trained in lung cancer, and I thought I was going to be a lung cancer doctor. When I started here, I was seeing different types of cancers, including lung cancer and GI cancers. And I happened in my first little bit of practice to get some neuroendocrine cancers that came through. Started to do a bit more reading about them. I had seen a little bit about them in medical school. I was aware of some things, but I certainly was not given a in-depth education on neuroendocrine cancer. So I had to start doing some more reading on my own, and just realized how complex this can be, and how much we need to tailor our care around individual patients. This is in terms of the cancers out there. Neuroendocrine cancers are unique in that they can be very different from person to person. And so it involves a lot of partnership with patients, a lot of partnership to create the right treatment plan for an individual. And I really like that. So I started to see more and more neuroendocrine cancers. I then asked my colleagues. At that time, we didn't have anybody at our center specializing in neuroendocrine cancer. I asked my colleagues if I could see the neuroendocrine cancers. And you know, I was met with a bit of resistance in that they didn't feel that someone could sort of make their career out of this. They felt that these cancers didn't need this much attention. There was ignorance among my colleagues, which is just an issue. I think many people find we don't have, even among the oncology community, it's improving, but certainly I feel that there's still more awareness to be made in the oncology community. You know, focus is often on the more common types of cancers. So that's where it started. And then, you know, if you build it, they will come. Once we had started to build a resource, we realized there's a lot of patients out there in the Toronto area and in Ontario and Canada that need help and want to be engaged. And so we had a lot of support. At the beginning, the hospital administration said to us, well, you can have some space on Friday afternoon. And Friday afternoon is when other people didn't want to be seeing patients. So I took it. I had a great partner with a surgeon, Dr. Calvin Law, and we started our own little small neuroendocrine clinic ourselves. And from there, it grew and grew. It grew to, you know, every second week. It was once a month, to every second week, to every week, to expand it all day. Then we, you know, we had a larger clinic. I started to really only see neuroendocrine cancers. We got a second surgeon. We now have a radiation oncologist, an endocrinologist, a number of trainees, a physician assistant, nursing, social work. We have a special neuroendocrine oral pharmacy program. It just really grew because there were patients out there that needed help and wanted to be part of this program. So that's kind of how it happened over the last 5 to 10 years. Yeah.
Okay, I was going to ask you when roughly that moment was when you were kind of like, hey, I'd like to just focus on these alone, and you were met with that resistance. You would say that was within the past
about 10 years, and it's been a consistent growth every year. And slowly, I dropped other parts of my practice and focused specifically on neuroendocrine cancers, and sort of we've been doing guidelines in Canada to try to help and improve, doing a lot of administrative work to try to make sure in Canada we can get the treatments for our patients that we need. Mm-hmm. So that's become a full-time job plus, yeah.
Do you think that other places around, I mean, we can just refer to maybe the States or around the world are still resistant, like that resistance you felt about 10 years ago. If they don't have a specialty center, is that something that we're still struggling with?
I think we are. I think it's improving for sure. I think as we've had more trials come through, as we've been more vocal as a community, certainly awareness is better than it was. I think we're making inroads. There was an impression that, neuroendocrine cancers are, patients live a long time. We don't need to treat them. We don't need to be aggressive. We don't need to meet their needs the same way we do for other cancer patients. And I think that's changing. I still think there's more work to be done, but certainly that has changed in the 10 years that I've been around or so. Yeah.
Awesome. So everybody at home, if you're just joining us or joined us a little bit late, we're here today with Dr. Simron Singh. And as he's told us, he deals 100% with neuroendocrine tumors. So we have an expert with us today. So if you have any questions, get them in. We have about 50 minutes left. But if you know someone else that would like to attend this session or would benefit from this, you can go ahead and you can tag them in the comments. You can share this video and let them know that we're going live now, so that maybe they can get those questions across. If they aren't, or if you want to refer back to this video, just know it will be evergreen and it will live here on the Facebook page. And starting Monday, we will republish it to the Carcinoid Cancer Foundation's YouTube channel for those that don't have Facebook. But if we can get people here now, let's get them here now, because I have a feeling that Dr. Singh is going to really be able to help some of you all. So that being said, Dr. Singh, we already have some questions pouring in. I feel like I could talk to you for a while. I'm really interested and we may come back to that. I'm really interested what led you to want to try to solve these unique case-by-case problems that NETs present. But the people are speaking, so let's help them out. So Heather says, should all PNET patients see an endocrinologist? This seems challenging at my center.
So thanks, Heather, for that. So I think it depends on the type of symptoms that someone's having. If there are symptoms of high glucose or high insulin, or they're having flushing and diarrhea or unknown rashes, it's probably worthwhile. But many of these issues can be managed by an oncologist who's familiar with neuroendocrine cancer. So I would say it really depends on if you have the expertise that's available to help address these issues. Do I think routinely everybody needs to see an endocrinologist? I don't think it's necessary, but you need to have somebody who's knowledgeable about what hormones a PNET can produce, so that someone can get the care that they need. So I hope that answers your question.
Okay. Kind of along those lines, and I have a question from Jennifer, who I know a lot of people deal with this. If you are in a small area and you do not have access to a NET doctor, what do you suggest to do if you have to deal with a GP to help make sure that you are getting the best care for yourself?
Jennifer, that's an excellent question, and that actually is a lot of the work that we do here. So Toronto, for those who aren't aware, is a pretty big city. It's the fourth largest city in North America. Our general area is around 6 million people. And we really discovered that it wasn't feasible for us to be, we just didn't have the capacity to see everybody. So a lot of my referrals come from other oncologists and other doctors that say, look, I don't have the expertise in this neuroendocrine cancer. Can you see this patient? Now, as you may be aware, I mean, Canada, like many places in the United States, is a very large area, and it's not feasible for patients to travel. We have bad winters, and snow prevents us from moving, all the time. So we've really developing a hub and spoke model where we provide care, and then they can get the day-to-day care at home. But when there's a fork in the road, or when there's issues that come up, or when we're at a challenging point in the care pathway, I'll get back involved. So I think if you can look for that sort of a model where your GP may be able to work collaboratively with one of these larger neuroendocrine centers, I think that can be a good model that makes it realistic, so you're not traveling all the time, but you're also getting the care you need close to home. One silver lining in COVID that's happened is this rapid growth of virtual care. I'm seeing a lot of my patients virtually now, and I can tell you they really are happy. They don't have to travel 2 hours in the snow to see me. And I'm happy too. I'm happy that they're happy. So that works out well when we can see things virtually. And a lot of the restrictions we had from a system, et cetera, have really been lifted and are moving much faster than they were before. So I think
Absolutely.
that's huge area where, from a neuroendocrine perspective, we can make some big progress as a community, because there's lots of people in that situation, Jennifer, that are not in an urban area where they have to have a neuroendocrine center close to them. And I think virtual care for neuroendocrine cancers is going to be very important in the years to come.
And you would also be able to use, virtual connection to talk with their doctors, with their GPs,
Absolutely, yeah.
This is great. You took the words right out of my mouth. I was going to ask this question, and it's similar with a lot of different fields, ours included. I mean, this program is essentially a product of the pivots that CCF has had to make during the pandemic. And as you said, this allows us to reach more people more consistently for less money and less time. So, I mean, this is something that will continue, but was kind of when our hands were forced, and I was, planes were sidelined, because I still travel a little bit for CCF. I have a trip coming up next week, but I used to travel every couple of weeks for these projects, and now we're able to still achieve the mission in this virtual setting. So I was going to ask that, and I'm glad that that's a possibility. So thank you, Jennifer, for your question, and hopefully that helps. This is a question coming from Pam, which I know that we've talked a lot about on the show. Her question is, when will targeted alpha therapy be available for patients? But I'd also like to kind of piggyback onto that and just get your opinion and your thoughts on alpha therapy, and maybe even an explanation for those unfamiliar with it. And then maybe we can talk about when that might be available. So what are your thoughts? What exactly is alpha therapy, for those that don't know?
So if we're talking, so thanks, Pam. I think when you're referring to alpha therapy, you're talking about sort of new forms of what I would call systemic radiation. So ways that we're giving radiation to the tumors. So one of the things that we understand about neuroendocrine tumors is that a lot of them have these receptors, and that's why we call these receptors somatostatin analogs. They're basically targeting these receptors, and these are the injections people are getting once a month, usually, or once every 28 days. Alpha therapy, now I'm not a nuclear medicine physician, but we do PRT, which I think most people are probably aware of on this show, but is radio receptor therapy. And it is a new basically form of radiation, different form of radiation. From my understanding, I would say the jury is still out on this, but it is a promising way. The clinical trials are underway. So I think if people are interested in alpha therapy, the best thing to do is try to look out for a clinical trial to see if they're eligible and it's available. I think the easiest way to do that is talk to your local physician or your local healthcare provider, or there's a great website called clinicaltrials.gov, which can be sometimes confusing, but it is navigatable. And you can sometimes search in your area for clinical trials that are nearby or even far away, and you can get some information on that. So that's what I would say. I think from a routine use of alpha therapy, I still think we're a little bit away. Probably, I would say a couple of years still.
Yeah. Just a plus one, what Dr. Singh just said, not about alpha therapy because I'm not an expert, but clinicaltrials.gov. We're actually working on another project that I do with CCF besides Luncheon with the Experts, is a produced video series. This year, we're doing a series on treatment and different aspects and elements of neuroendocrine cancer. And so the one coming out next is on clinical trials. And that website, clinicaltrials.gov, is very thorough. You can use the map function and literally click on your state, and it'll go down, I believe, even to your region, to clinical trials that are going on. And in the video, as a little teaser here, we have a screen flow and kind of walk you through that and show what it will look like. But it's like Dr. Singh said, it's pretty easy relatively to navigate, but super helpful, super thorough in terms of what's available out there. That being said, a quick question about clinical trials. For this disease specifically, how important do you think it is for someone to seek out a clinical trial?
I mean, I think it's very, I mean, we really need to be able to understand new treatments and to be able to get access to that. Sometimes the best way is a clinical trial. And in the last, when I started, when we talked about this clinic, at that time, there wasn't a single clinical trial in neuroendocrine tumors. And in the last 10 years, we've seen a really rapid growth of that. That's because of active involvement of patient groups and patients and patient communities saying, we want access to new treatments, we want access to clinical trials, and voting with their feet and coming to the clinical trial and saying, I want to do this. And that has enabled us, where we were 10 years ago to now. And that, as we were discussing earlier, Rain, was that brought the attention of other oncologists to say, wow, there is some development here. This isn't, just a sleepy area of oncology. This is, we need to sort of be involved in this. So it has had benefits on numerous sides of things.
Absolutely. And I love the vote with your feet. This is a saying, not this particular saying, but this is a concept that we deal with a lot on the show of being your own best advocate. Stand up for yourself, speak up. And yeah, I definitely agree with that. Okay. So Erica has a question about your clinic. Do you have any studies of new treatments in your clinic? And if so, what in particular are you studying?
So thanks, Erica. Yeah, I mean, that's one of the advantages that we've had by having this clinic is we're able to bring clinical trials in and we're able to offer it to patients. So right now we have a number of clinical trials going on. We have one clinical trial on embolization in the liver. So that's liver-directed therapy for cancer, neuroendocrine cancer, primarily in the liver, where we're looking at different forms of embolization. We just wrapped up a couple of clinical trials on immunotherapy that we were able to work with one of the pharmaceutical companies with to see if immunotherapy, we've seen great strides in immunotherapy in other types of cancers, melanoma, lung cancer, and it was only fair and logical that we try this in neuroendocrine cancers too, to see if we can get that same sort of response. One of the trials we're running right now is called the NETTER-2 trial. So some people may be aware there's a trial called the NETTER-1 trial, which was sort of groundbreaking. It was published in the New England Journal of Medicine, which in medical terms is as good as it gets. And it was looking at PRRT, and it was the trial that got PRRT approved in Canada and the United States. The NETTER-2 trial is obviously the sequel to that. And it is looking at first-line PRRT for slightly more aggressive neuroendocrine patients with a Ki-67. I believe it's 10 to 55. So Ki-67 is a marker, for those who aren't aware, that we use to sort of classify the tumors. So for these slightly more aggressive neuroendocrine tumors where chemotherapy perhaps isn't the right option, but we want to be a bit more aggressive, it's looking at first-line PRRT right from the get-go to see if that'll improve things. So we have that running right now, and I believe we are the global lead in recruitment. So I think having a center where you can have people know it's a one-stop shop for your trials can actually, again, it helps us get people on trials, but it helps patients make sure they know where to go for access.
Awesome. Great. And actually, Erica, that we answered her second question. She had a follow-up question about running Sunnybrook running any open clinical trials, but she did say, how does one participate? Is there an easy way for her to get in touch with the right people there?
Yeah, I mean, if you're in the area, for sure, you can get your oncologist or your local doctor to refer in, and where we can do either a virtual visit or an in-person visit, depending on the circumstances, and sort of assess if there's a clinical trial that would be appropriate.
Great. Awesome. Thank you, Erica. Hopefully that helps. Great questions. So we have another question from Emily. Emily says, my oncologist will only check my tumor markers and do a CT scan every few years because he says that the gallium scan is outdated. Is that sufficient, or how do you feel about that statement? Can you talk to us about the gallium scan and how you feel about it?
Sure. So thanks, Emily. One of the uniqueness of Canada is that we have a public healthcare system, and so we do a lot, and we probably get our treatment slightly slower than in the United States. We get them a little bit later, and so gallium scan is now sort of being used more and more in Canada, and that has given us some time as well, though, because we have to work with the government and to reflect on where the evidence is, and it really. I can't necessarily answer your question exactly because obviously there's circumstances, but I think a gallium scan, in my point of view, is very useful when we want to know if PRT, for example, is an option, or we want to understand if you have receptors. I think before surgery, gallium scans are very useful so that people can map out where the cancer is before they do surgery. I would say anytime a gallium scan would potentially change the way we might treat the cancer, it's probably a useful tool. So if we think that if the results of the scan would one way or the other suggest something different in terms of treatment or actions, that's when it may be useful. If you're referring to when a cancer has been resected and we're sort of looking for it to come back, I say that the evidence for that is still questionable. I wouldn't say it's different, I guess, location to location. But normally what we would proceed with here would be a CT scan, and then we would proceed to a gallium scan at a very low, if there's any question at all, then we might go forward. So I guess it's a discussion that you'd want to have with your local doctor. In terms of the idea that gallium scan's outdated, I think it's sort of the standard of care now. There is a new scan with copper that's just been approved weeks ago, but that is sort of really brand new, and I don't know what the availability of that is right now.
Yeah, I've been hearing about that one as well. I actually saw a comment later in the thread from another attendee that, you know, there may have been some confusions, and the other attendee said that she thinks that she was referring to the Octria scan. So maybe is that a little outdated?
I think that makes more sense. So I do think an octreotide scan, I would suggest if we can do a gallium, we should do a gallium. I really would encourage us to move away. Octreotide scans are outdated, and I think a gallium scan is much better. If you ask me between a CT and an octreotide scan, I think a CT is probably a better option.
Got it. Okay. Thanks, Emily, for your question. And thank you also, Shannon, for chiming in there. This is what I love about this community. We're all here to help each other get the right answers and the right information. So I have an interesting question from Kim. It says, we hear about the genetic issue or concerns a lot. She says, what genetic testing, if any, do you do for normally do for people? And then she says, any funky ones? Which I like, but I don't really know what that means. But, you know, this is a topic that I think maybe we can talk about. Is there any genetic testing that you do?
So in select patients where we have a level of suspicion, so MEN1 is a type of genetic disorder that can occur where for patients who are young, often with pancreatic neuroendocrine tumors, they have a history, for example, of parathyroid or, you know, thyroid disease or anything else, we would send them to our genetic counselors to test for MEN1. Right now, that is probably the only sort of routine genetic testing that we know of. But what is happening more and more, and to answer your funky one, is there's this whole new thing in the world of oncology that's called whole genome sequencing, where they take your whole genome and they try to map it out and look for mutations. Now, this has been really useful for some other cancers. Neuroendocrine cancers don't have a lot of mutations, but we have used it in situations where we've sort of tried all our common treatments and we're still stuck, to see if there's any doors that open up. So I think as that moves forward, we'll probably get more information. Is trying to understand if maybe not for all neuroendocrine cancers, but maybe it might help guide us on certain situations, specific mutations. So that's probably a big field moving forward, is the whole genome sequencing.
Got it. I've heard some people talk about that as well. Next, we have a question from Vanessa, and everybody at home, we're about halfway through, so continue to send in your questions. Dr. Singh is knocking them out of the park. Vanessa says, have you had many NET patients have success with SBRT? And is Sunnybrook the only center to offer this? So, of course, let's go ahead and establish what SBRT stands for and what that is. And then the follow-up or the secondary question is Sunnybrook the only center to offer this?
So thanks, Vanessa. You've obviously done your homework here, because so SBRT, you're gonna catch me for what this stands for: stereotactic
body radiation therapy.
Body radiation therapy. Okay. I was trying to figure out what the B was for.
Yeah.
So it's SBRT. Really, what it means is really high dose focused radiation to a specific tumor spot. Often we think of it in liver. So if there's like 5 liver spots, you do you really fine tune the radiation to that spot. And you almost think of it like they call it radiosurgery sometimes. It's like precise high dose radiation to kill that tumor at that spot.
Okay.
I think there's a lot of potential in this moving forward. We've always been told that, you know, there's 3 modes of sort of oncology therapy. There's surgery, there's medical, and there's radiation. And we've always been sort of traditionally told that surgery and medical that are part of neuroendocrine therapy. I think there is a role for radiation. We have Dr. Sten Meyerhog here, who is a colleague of mine here who's very interested in this. And we've been working together for some time now to try to explore how medical therapy and radiation therapy can work together to provide outcomes. One of the trials we completed doing was looking at everolimus, which some people may be aware of, Afinitor, which is used. It's a pill form, combining that with that SBRT radiation. So I would say Sunnybrook's been a leader, at least in Canada, and I would say in the United States too, in using SBRT. And I certainly think it's something that we should be exploring more for people, for the right patient, for people who have limited disease in their liver. This may be a good way of dealing with some of that cancer that often doesn't have a huge amount of side effects either.
How long has SBRT been available?
So radiation's been around forever. SBRT is sort of a new technique where they really focus it narrowly down. And I'd say it's been growing over the last 10, 15 years, more and more. And we're seeing its reach sort of expanding to other types of cancers, other roles, a bit more spread. In neuroendocrine, it's still pretty new.
And this is a personal question, but the difference between SBRT and PRRT is the binding to the receptors with the PRRT. Is that accurate? Or
it's a really good question. So when we talk about PRRT, I like to think of it as systemic radiation. So it's almost like the radiation is injected into you, and it travels to your tumor and binds to the receptor. The receptor takes in that little isotope, and then it decays and gives. SBRT is like external beam radiation. So it's done externally to your body, and a beam is given. It doesn't it doesn't get delivered through the bloodstream like PRRT does. Got it. People may be a bit more aware of this type of radiation. For example, in breast cancer, they use it a lot, or in head and neck cancer, they use a lot. But this type of focused radiation therapy is given through an external beam, whereas PRRT are small little isotopes that are injected into your blood system.
Awesome. Thank you for that. That actually cleared up very, very well for me. I appreciate that. So you had mentioned at the top of the program that I think initially either you were working in lung cancer or thought that would be the area in oncology you would spend your time. Do you deal with lung net patients?
I do.
Okay. So we have a question from Michelle, asks if you have any experience with dip neck. This is something that people ask about a lot. In fact, sidebar, everybody watching, I'm currently working on a video for the treatment series that I'm doing for CCF on lung nets and dip neck. So hopefully we can have more information on that, but for you. But Michelle says, any experience with dip neck? I'm interested in clinical trials for it and not finding any. So how can we help Michelle learn a little bit more about dip neck and maybe find some treatments?
Sure. So thanks, Michelle, for that question. I think if you look, we talked a little bit about how neuroendocrine cancers maybe have been neglected for some time. I would say within that, the lung neuroendocrine tumors are probably even more because they're less understood, and people don't realize that there's such a large number of lung neuroendocrine tumors. In terms of dip neck, it's a subtype really of a small collection of very small lung neuroendocrine tumors. To date, there was one clinical trial that started specifically on lung neuroendocrine tumors. That was only lung neuroendocrine tumors. Unfortunately, it wasn't successful, and so that trial was stopped. Right now, I'm not aware of any dip neck specific clinical trials that I'm aware of, at least on a large scale. One trial that may be coming forward, and I think I can advertise this so people can know, is a trial looking at PRRT in lung neuroendocrine cancers. I don't think it would include dip neck, but it will include lung neuroendocrine tumor cancers. And that's being led by Dr. Tom Hope out at UCSF. And so hopefully that'll start to become available over 2021 as well. So that is an exciting development as well for lung neuroendocrine cancers. For dip neck, I'm not aware at this point of any specific clinical trials, but I think it's an important area because our understanding of it needs to grow for sure.
And dip neck often is affiliated with lung nets, correct? But not always.
Yeah, it's almost a complicated in that it's almost like you have small spread of minor tumors or smaller tumors that have potential to become a bit more aggressive, but not necessarily. So it is. I would suggest it's really within the family of lung neuroendocrine tumors.
Yeah, okay. Thank you. And Dr. Tom Hope is a friend of the show, so shout out to him as well. So we have a regular, Bernard from Kenya, who always attends. What's up, Bernard? Good to see you again. And to go back to the clinical trials, his question is, can your clinical trials be done outside of Canada, like in Africa? And if not, any thoughts or suggestions for him living in Kenya?
Yeah, no, that is, thank you, Bernard, and thank you for that. Clinical trials are very highly regulated, whether it's by the FDA in the United States or Health Canada in Canada. They have very strict criteria. Sometimes it's frustrating for us as clinicians. They're, if your one number is off or sometimes off, our hands are tied. So it is at this point to do. There are some global clinical trials, like this NETTER-2 clinical trial. So they're done throughout Europe or Asia or Africa. So it's sort of finding out if there's local, but you need to have a center do it locally or somewhat locally. So I think, unfortunately, it's hard to do remote clinical trials, but there are global clinical trials that do take place, and we're doing more and more of them in neuroendocrine cancer. So in Kenya, what I would ask is, is to ask your local provider if you know of any, probably the local cancer center or the local cancer hospital, or if they are doing any clinical trials moving forward. Yeah. In terms of care overall, I think, again, going back to our discussion about virtual care, I think that's going to be being an advocate for yourself, which you're obviously doing if you're here every session listening to Rain and everybody, but also finding out in terms of virtual care. They're where before you had to travel to see people. I think that door is going to open quite a bit, where you can get consults and get other people involved in your care remotely, even if you're a continent away.
Awesome. Thanks, Bernard. Hope that helps, my friend. Erica says, thank you for answering my question. You're the best. I will parry that back to you and say, no, Erica, you're the best. Your questions were awesome. Thank you. Okay. Another question that I see pop up a lot, Dr. Singh. What is your opinion regarding the NET test? First of all, are you familiar with the NET test? I see you nodding, so that tells me yes. Thoughts on it? We hear, mixed feelings, or people that maybe want a little more information on it. Where do you stand? What do you know about it?
Listen, I think, so thank you very much for that question. I think moving forward, we need more individualized therapy for neuroendocrine cancer. So, taking a step back, I think one of the challenges, but also one of the reasons I got into field is neuroendocrine cancers are not one cancer. So, and that's true for all cancers. There's differences in breast cancer, colon cancer, but I don't hesitate to say, I think as a family, neuroendocrine cancers are a bunch of different diseases. And somebody who has a low-grade neuroendocrine cancer versus someone who has a high-grade neuroendocrine cancer, those are two different types of diseases. And as we move forward, a lot of my work is in clinical trials and designing sort of the plans in the future of how we're going to move this field forward, at a national and international level. I think we recognize that we have to sort of individualize care as much as we can. And that takes into account the disease, that takes into account the patient, and that takes into account the system, as we were talking about before, where you live and where you have access to. That might change the treatment plan that we make. So I think the NET test can be a valuable tool to help individualize care and help us understand things a bit more. And I think we need more predictive markers. So when I say predictive markers, in other cancers, such as colon cancer, there's certain tests that we can do to help us understand, this patient is more likely to respond to treatment A versus treatment B. And I think we need more of those in neuroendocrine cancer, and the NET test is one of the promising predictive markers that may help us guide us in that direction.
Awesome. Thank you very much for that thorough response. And everybody watching at home, we did have the creator of the NET test, Dr. Irvin Modlin, on the show, first episode back in July. So if you go to the videos tab, and in fact, I think the videos are broken into different series. So we have one for Luncheon with the Experts, and you can scroll back to that episode if you want to dive deeper and learn a little bit more about it. We had the creator of it on the show, so we learned a lot that episode. But we've been doing this for months. That was a while back now. Okay, moving on.
I haven't seen that video, but I certainly can say Irvin Modlin is an entertaining gentleman, so I'm sure
he certainly is. It was a great first. This was a new venture for us, Luncheon with the Experts. Like you said, we're doing these weekly, and that's an undertaking. I'm very happy with the impact that it's had, but he was a great first guest because, it was a new thing for us. We weren't sure how it was going to go. And yeah, he's entertaining, great personality. We hit it.
What you believe, I would suggest watching it. I'm sure it'd be a good hour.
Yeah. He was great. I was still finding my my bearings and the flow of the show and the tone of the show, but he was a great first guest. He helped us out with that. Okay, we have just shy of 20 minutes left, everybody. So get your questions in now. You've been a great audience today. You're asking excellent questions. Myself and Dr. Singh are very, very impressed. We appreciate you. Shannon says, no, where was I looking? I lost that. Sheila, pardon me. Sheila says, is there an improvement for testing MEN1 and MEN2A?
Thanks, Sheila. I'm just gonna be honest with you. I would say no. I think it's challenging it frustrates me when I have to get that testing done for my patients. That it takes a while and it's not so straightforward. So I think again, it's something that we could improve on as a community. It isn't the easiest test to order, and it's certainly we're not always clear on how and when to get it done quickly. Yeah.
Yeah, no, I appreciate you. I appreciate you being honest. I have a question. You know, when we started talking on the program today, we talked about, you know, kind of the strides that we've made forward in the past 10 years. And I don't think that your choice of that, you know, range or those, you know, those dates, that amount of years is unique, because a lot of the doctors I talk to, there seems to have been a lot of great strides that we've made in this disease in the past decade specifically. Obviously, in the past 40 years, we have too, but a lot has happened in the past decade. So my question is, let's forecast. Let's look forward into the next 10 years. We've had so many strides, and we've learned so much, and had so many new forms of treatment become available in the past 10 years. What do you foresee coming in the next 10 years? Do you feel like we can, you know, stick on that same trajectory? Will it hockey stick, and we really be able to help the people of the community? What do you see coming in the next decade?
So it's a really good question. I think a couple things. One is, will we see the same pace? I don't know if we're going to see the same pace, because at the beginning of this last decade, we really needed treatments to be able to offer. And we've started to see that. And now the bar raises, because now we have some treatments and we've got to prove that they're better than what we have right now. So I think we're going to see some improvements for sure. But I think the focus of the next decade, and then just taking back to what we're saying, is I think there's going to be more about individualizing therapy and making sure that people get the right therapy at the right time, at the right place. And there's a number of ways to look at that. Partly is those predictive factors like we were just talking about, but I think of it in terms of a couple of things. One is the disease. So understanding the disease a bit better, subclassifying the disease so that as an oncologist, I can say, you know, I have these treatment options, but I think for you, this is the right treatment option because of these reasons. Or this is the right sequence of treatments. You know, we don't know what the right sequencing is. We're challenges. So I think answering those questions is going to be important so that we can be more effective, even with the therapies that we have. Yes, we're going to get new therapies, and yes, we're going to be improving all the time. But I also want to be able to say that we'll be able to get the right treatment for the right person at the right time. So partially it's looking at the disease, and then part of it is looking at the patient and saying, you know, where does this fit in your life, and how does this fit in your life? We're doing a study right now. So I co-started with one of my colleagues in Australia, an organization called ComNets, which is the Commonwealth Neuroendocrine Tumor Society. And for lack of, it was New Zealand, Australia, and Canada. And we got together and we formed sort of a collaborative. And the reason we did this is because our healthcare systems are somewhat similar, and we all have, you know, smaller populations in a really big area. So that can be challenging to treat NETs. So we got together to do that. And one of the projects that we're doing is something called Direct NETs, which is a survey. It's called what we call a discrete choice experiment, where patients are given choices. And that could be in terms of, if you were to get, you know, option, let's take it out of disease. If you were to live in a city that had good public transport, but rained all the time, versus a city where you could go surfing, but you had to drive everywhere, what would your preference be? And everybody would be slightly different. And then you make a choice, and then it gives you another scenario. You had a city where restaurants were great, but the commute was horrible. And so it takes all the factors that may be important and helps individualize where the right city for you. You know, should you live in Texas, or should you live in LA, or should you live in, you know, a smaller community? And so we're trying to do something like this with neuroendocrine cancer, where we talk about the different treatments, what the expected side effects are, what the impact might be on you in terms of days away from work, what the impact may be in making an unplanned visit to the hospital, what it involves with you in terms of the type of side effects you'd get, and help make decisions in those clinical scenarios that would help guide treatment. And so if people want to participate, that's open right now. There's a website. It's called direct-nets.com, and you can go on there. And it takes about 15 minutes to do, but it's helping us try to understand what is important to patients, because I think that can be different from patient to patient, but it also may be different than what we traditionally think. Quality of life and how we manage our lives in the midst of dealing with this disease is important. So we got to put it all together. So I think that's where I think the next decade is going to go. It's going to be individualizing treatments, right treatment, right person, right time, and bringing that together as a package.
That is so cool. I really like you explaining it that way. So true. And for those at home, generally we have our COO Grace Goldstein on the back end. You might see in the comment thread sending these resources that may be mentioned. So instead of you trying to pause the video and go right to the website, I bet you in about 2 seconds that will be up and available on the comment thread. Just an FYI. So we've got just about 10 minutes and some change left. So I want to churn through and get to some more questions. I think that is just very interesting and a very great analogy with the living in the city and just the other, all the things that you have to. I mean, I just moved into a new house this summer, and there was a lot of things that my wife and I had to consider. And I think that in disease, often we or at least historically, traditionally, haven't thought about it that way. There's so many elements to a patient's life that play into this. I really like the way that you put that. I appreciate you for that. So Linda says, when is an MRI appropriate for a follow-up? I had a primary intestinal obstruction net with many metastases.
So thanks, Linda. An MRI is a slightly better test to look at the liver specifically than the CT. That being said, again, I think it comes down to a practical consideration. If the MRI is going to potentially going to change the way that we might manage things, then I think it's worthwhile doing. Now, an MRI also involves, if you're claustrophobic, it can be a difficult test. It can be a little bit more nerve-wracking. So things to consider is, do you really, is it going to change things moving forward? More is not always necessarily better. I know my surgical colleagues, when they're thinking about surgery, often will do an MRI because they want to sort of make sure they have the complete picture. If we're looking at, for example, whether a treatment worked or not from a radiological point of view or from a picture point of view, we want to compare apples to apples. We would compare CT to CT or MRI to MRI. So it sort of depends on the situation. And again, I think the general principle is, would this change the path forward if this test was done? And I think that can sort of, in most situations when we're wondering if we should get this test or that test, it's at least a good rough way of looking at things.
Awesome. Thank you for that. Question from Lisa, who is a top fan. What's up, Lisa? What treatments and trials are available and or appropriate for those with metastatic nets without receptors?
So that's a really good question. Thanks, Lisa. In terms of, those patients without receptors, so PRT probably is not a good option for those patients. We don't certainly want to use treatments that we don't think are going to be useful. I think those we want to look more at like the targeted therapies. We're starting to look more and more at like, usually they're pills, but more targeted therapies. Things like, there's this new drug, sorafenib, or other sort of drugs that are potentially being tested. So I think those are very promising. There are some early studies that are being looked at in terms of people who have low levels of receptors. If we can increase those receptors so that we could potentially use the same other treatments like PRT, for example. So I think what we would call, most people would use this term, but like sort of novel agents, like new sort of ways of looking at the cancer would probably be useful, and less useful would be the PRT type treatments.
Got it. Well, speaking of PRT, I have a question from Jackie. It says, I know you said that you aren't a nuclear medicine specialist, but I hope you can address the following question. Now that we have access to Lutathera in Canada, can you help us understand how Lutathera differs from LU-177, Lutetium-177 that was being offered in Canada before Lutathera?
Okay, great. So thanks, Jackie, for that question. we started off, so when we first tried to bring PRT into Ontario, our province or state in Canada, Netter 1 hadn't been released yet. So we worked with a company to try to look at privately if they would run a clinical trial to sort of at least get access. So lutetium-177 is simply the isotope that exists. It's basically just the isotope. Lutathera is the commercial product that links it to the receptor, etc. And numerous other ways, there's numerous ways to do it. So lutetium-177 is just the name of the isotope that is decays, but Lutathera is the name of the commercial product. Lutathera sort of comes as a package and it's all linked and everything for you. What was available before was just another version of that, but it was still lutetium-177. It was the same isotope, just from a different, it's like Coke and Pepsi.
Perfect. Awesome. Thank you. Kelly says, thoughts on carcinoid ileum tumor that has metastasized to the liver and mesentery?
Thanks very much for that question. I mean, our first line, there's a number of other pieces of information how aggressive is it? Is it symptomatic? How much is it impacting a patient's life? But certainly in most situations, we would start with what we call somatostatin analogs, which is the injection that you would get once every month. That would be our first line of treatment if it was appropriate. And then second line treatment would either be PRRT or everolimus or Afinitor after that.
Got it.
One thing, Rain, I should mention is to also to be assessed by a surgeon, because sometimes even if these tumors are not symptomatic, they can be. And it's better to deal with that early and prevent what we call a bowel obstruction than to have it happen when in the middle of the night on, when you're on holidays or something and you want to deal with it proactively. So even if you're not symptomatic with a small bowel ileum tumor like that with spread to the mesentery, I think it's always good to see a surgeon to say, should we be acting on this now?
Got it. We keep coming back to this aspect of, treating people and seeing where this fits into their lives, lifestyles, etc. What is some of the initial advice you may offer to a patient with this disease in terms of that, from that perspective of what are the things they should consider, all the things they should consider when dealing with this, when they're really trying to answer that ultimate question of like, okay, where does this fit into my life? Does the question make sense?
Yeah. So again, every patient's different and every tumor is different. But when we can, what we want to get to is a point where people are learning to live with this and are able to go on to their normal lives. So I often use the analogy, people live with diabetes, people live with arthritis, people live with, we can't cure those diseases. Diabetes, we can't cure. So even if we can't cure the neuroendocrine cancer, we want to get to a point where we find the right mix where people can live with this disease and they can they have to manage it. They have to, let's say, get the injection every 28 days and they have to see their oncologist and get scans every X amount of months, but can still go on with their normal life. That's where where we want to get people to. Sometimes we're successful and sometimes it's more challenging, but certainly that's sort of where we'd like to be, is that this is a disease that we're going to live with, but we want people to be able to get on with their lives. And for different people, that means different things. And that's part of this idea of whether it be that direct next study or just, exploring what is important for people in terms of maintaining their normal lives. What do they need to be able to get to that point?
What is important to people? Yeah. And I think that's a tough question it's an important question to ask, but sometimes tough for people to really understand, like, well, what do I value? What do I value in my life? What's most important to me?
Like, for example, if there's a treatment where it's going to require you coming into hospital every week and you're going to be, I'm not saying that it is, I'm just making this up.
Sure.
You come in every week and you're sick for every 2 days out of that week, and, you can't spend time with your family, and, someone else, you can't spend time with your children the way you want to, then that may not be worth it to you. There may be other options, even if they may not have the same, publication behind it, et cetera, where it actually makes more sense for you to manage your life and you can still manage the disease. So I think finding that balance is different for different people. And our job is to help support, I think as an oncologist, our job is to help support people to find what that right balance is for them and to provide them the information so that they can make those decisions moving forward.
Absolutely. I have another question from our old pal Erica. Erica says, and I'll see how you feel about this question. What's the longest you've had a net patient live with net cancer?
I mean, I'm not going to give exact numbers, but I would say
Yeah.
it's not uncommon to see decades, right? We have patients that have that are living on decades,
Yeah.
in
Let
fact,
me
we have.
ask let me ask you this follow up then that may give a little bit of more insight. Are there patterns that you see in those people who do tend to live a long time with this disease? Are there recognizable patterns of treatment that they've had, approaches that they've had, any ways their disease has developed, anything like that?
Yeah, I think, and that comes down to some of those factors like, the grade, the extent, how well they've responded to treatment earlier on, and unfortunately, it's not everybody that we can get those sort of results from, but certainly there are some type of tumors in some patients when you put all these features together, that we can get to that point and we're successful together. Certainly when we're doing teaching about this, and this is one big advantage of our clinic, is we've been able over the last 10 years to do what we have a lot of trainees come through our clinic and training the next generation of oncologists to be at least aware of neuroendocrine cancers and know where the resources are. But one of the things I do first of all is to teach them about there's no one aspect of this. You need to look at this cancer from 5 or 6 different lenses to be able to put that all together to answer those questions. Yeah.
How much has, let me see how I can phrase this, how much has it changed for your general oncologist to know about this specific cancer, this specific disease, since maybe when you started, or we can take that 10-year increment we've been
Yeah.
dealing with in the past 10 years? I don't know if you can put a percentage to it, but how much do you think that has changed, and what?
I think quite a bit, to be quite honest. I
Yeah.
think the impact's been quite large, both because of, as I've said, there's been a lot of advancement in the last 10 years, and it's made people notice that there are effective treatments, one. And then two, I think just having the education. We were just discussing yesterday over the last, 10 years, we've had so many people come for rotations, and as they rotate in our clinics, they get a baseline knowledge of neuroendocrine cancers that they didn't have, that I was never taught. And so that at least enables them to know that if they do have a patient with neuroendocrine cancer, where do we, even if they can't remember it all, or they can at least look it up, or they can reach out to us or to their local sort of neuroendocrine center. And so I think that's made a big difference. It's helped really put it on people's mind, at least.
Awesome. Last question. When you tell someone that they have this kind of tumor, how do you deliver that information to them? What do you tell them outside of course, the fact that they have? What's the first bit of information that you give them when you tell them that they have this disease, which I wouldn't say certainly, but almost certainly, or most likely they've never heard of before?
So I think the first thing to recognize is that this can be complex. If it's complex, as we were mentioning, if it's complex for my colleagues, it's certainly people have medical training. It's not, we think of cancer in a very uniform way, and neuroendocrine cancers are not uniform by any means. So I think it's recognizing that when we first start, it's an ongoing discussion. It doesn't happen in one day. I think we start talking about some of the features, for example, where is it, the hormones, what are potential broad steps moving forward, but recognizing that these discussions have to continually happen because you're not going to absorb everything on that one meeting. We encourage patients to have family and caregivers involved, so that there's a second set of ears, there's a second person listening, and to continually have that discussion moving forward. So I think it's a gradual process, but I think, to directly answer your question, what we want to do is talk about, where the disease is, what are our aims here? What are we aiming for? Is it control? Is it cure? Quality of life? And what are potentially our options are? And then slowly build on that in subsequent visits.
Awesome. Outstanding. Thank you, Dr. Singh. You've been awesome today, and everybody at home, the numbers have stayed nice and high and sustained through the whole episode. So I appreciate you sticking around and staying tuned. But thank you so much for joining us today. I also see in the comments, I didn't get the chance to mention them all. People were saying things like, let's see, how great the information was in this session, and how great the show is. So I really appreciate you taking some time and being a part of it.
No, no worries. I think it's great, and congratulations to the team. I know Grace, and she's done an amazing job at increasing awareness.
Truly.
And so this is a great endeavor that you guys have done. So those congratulations to you for that.
I appreciate that. And one of the things I tell Grace every week, because we always chat about the show, we're very happy with it. She pretty much handpicks everybody that's on this show, and I tell her way too many times, not too many times, but I tell her all the time how great of a job she does. So I'm glad I get to say
Oh,
that
Grace,
publicly today.
uh,
She knows the people. She brings on great guests like you, and I mean, this series wouldn't exist without her. So shout out to Grace. I know you're out there watching.
and one thing I need to tell your people are watching, Grace is an incredible advocate for patients. At every meeting I'm at, that's why I met her. Every meeting I'm at, every time there, Grace is front and foremost, making sure that the patient's voice is heard, and I really appreciate that. So again, kudos to her for that.
Absolutely. She works incredibly hard to help the people with this disease. So I definitely plus one that. And thank you all at home for joining us today. As always, we hope that this program has helped answer some of your questions. And again, I'll reiterate that I want you to please reach out to Carcinoid Cancer Foundation, either at their website, carcinoid.org, or here on the Facebook page. You can direct message them for further information, or if you have other questions. Thanks again to our presenting sponsor, Tricera Therapeutics. Without them, this program wouldn't be possible. And again, my name is Raym Bennett. Thank you for watching. Please join us next time for Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.